Hello students, I am Dr. Ramakrishna Chaitanya, your anesthesia faculty. So here I am again to do this INI-CET November session recall session of anesthesia, right? So I hope you guys have written this examination well, right? So it's not like this question paper, INI-CET question paper. Yes, there are, like as usual, some routine questions are there from anesthesia side I am talking about. So there are some routine questions are there. I don't say it's a bouncer, but yes, there is one clear-cut bouncer from the anesthesia section. But apart from it, as usual, there are some around 5 questions, 6 questions that have been asked directly from the anesthesia. Most of the questions are pretty straightforward, except for the one question which is slightly tricky. And I don't think, and that too, you can easily rule out things. And there are 1 or 2 questions which are associated with anesthesia, but not clearly anesthesia. So what I will do in this recall session is I'll quickly try to recall all the questions that have been asked from the anesthesia segment. I don't want to jump into surgery or pediatrics and say, yes, this is my question, my question. So because that faculty will be reviewing all these questions also. So I don't want to repeat the same questions again, but exclusive anesthesia MCQs I want to discuss in this module. So without wasting much time, shall we move to the next session, right? So what's the first question that has been asked in anesthesia? So yes, this is a pretty straightforward question. Jackson-Rees circuit is used for. What is Jackson-Rees circuit? So Jackson-Rees circuit is Mapleson F circuit. Mapleson F circuit. The name of Mapleson F circuit is called Jackson-Rees circuit, and this is the circuit of choice for children. So what is the correct answer? The correct answer is pediatric anesthesia. Now see here. Of late, if you see the last few years of question paper, there were not many questions on the circuits. As I said you in the video lectures also, circuits are one area for an undergraduation level. Most of the times, they will not put any complicated questions for the examiners or for the undergraduate students. Yes, the topic itself is a complicated topic. But for undergraduation levels, if you remember some of the basic facts about the circuits, that is sufficient. And after so many years, if I am not wrong, after more or about 4 to 5 years, there were not many questions on the circuits. Even before this 4 or 5 years, the circuit questions were pretty straightforward questions. So let us quickly recapitulate the circuits, what we have discussed. So the circuits are basically classified. Circuits are also known as breathing system. So breathing systems, they are basically classified into breathing systems into 3 categories. Okay, that is called open circuit. Of late we are not using this open circuit. This is called as Schimmel-Busch mask. Schimmel-Busch mask. It is like, if you want, I am not showing the image, but in the video section we have already showed this. It is like the guard what we use in our cricket. So it's more or less like the guard, right? So it's like it's having a mouthpiece, and you can put it on the nose and the mouth. You have to cover it with a gauze piece and put some ether and chloroform. The patient will be anesthetized over it. So of late we are not using this open circuits. The second one is called semi-closed circuits. These are very popularly known as Mapleson circuits. Mapleson's circuits, right? So this Mapleson, he has divided this semi-closed circuit into 6 categories: Mapleson A, B, C, D, E, and F. Right now, if you remember some of the fundamental facts about this Mapleson circuits, that covers most of the questions in your upcoming entrance examination also. What are those fundamental points? Mapleson A circuit is called as Magill's circuit. Magill's circuit, and this is circuit of choice for spontaneous ventilation. Spontaneous ventilation. The modification of Mapleson A circuit is called LAC circuit. What is the modification they have made in this LAC circuit? Means it's a coaxial circuit. What do you mean by coaxial? Means circuit within a circuit. So you have one circuit, and inside that circuit there will be one more circuit will be there, right? So this is called as coaxial circuit, right? Now B and C circuits, of late we are not using it, they are obsolete. Of late we are not using it, so don't worry about it. D circuit, Mapleson D circuit is the circuit of choice for controlled ventilation. controlled ventilation, and the modification of Mapleson D circuit is called Bain's circuit. Bain's circuit. Right now, Bain's circuit, what is the modification? Again, this is a coaxial circuit. So how do you differentiate between a lag circuit and Bain's circuit? Means in the lag circuit, as I said, you unless and otherwise you work with a circuit, you cannot understand it. This is also a coaxial circuit. So here the inner tubing of the lag circuit carries expiratory gases, whereas inner tubing of a Bain circuit will carry oxygen. So that is the biggest difference. Sir, how to differentiate in the image? You cannot differentiate. You cannot differentiate. The only thing is, if it is an expiratory gas, this expiratory gas will be connected to a APL valve. It is connected to a APL valve. Whereas if it is an oxygen, it is not connected to the APL valve. So that much amount of depth you will not, they have not asked in your entrance examination. Till now, they have asked only the names of it. E circuit is called INI-CET. And this is the basis for the construction of the ventilators. If you open up the ventilator, you can see this kind of circuit where this is a INI-CET piece. Okay. Again, the modification, what they have done in this INI-CET piece, that is called as F circuit, that is called Jackson-Rees modification. Jackson-Rees modification of E circuit. So they have not put it under same category, they have kept it under separate category, that is called as Jackson-Rees modification of E circuit, and this is the circuit of choice in children or pediatrics. So this we have repeatedly discussed in the video section, in the revision section, in the notes, and it is not a new question also. So one point, if you want me to add, the A circuit is the circuit of choice for spontaneous ventilation. The fresh gas flows should be equal to minute ventilation. If you remember this much, that will be sufficient. Why it is minute ventilation? All these factors, it's too cumbersome for an undergraduate student. For those who are preparing for the entrance examination, if you remember this much, that is sufficient. And in the Bain circuit, the fresh gas flow should be 1.6 times minute ventilation. So in a nutshell, I have covered this entire circuit so that it acts like a revision, not only telling you the answer for the question, but quickly I have want to revise everything regarding the circuits. So if you remember this much, majority of the questions you can easily understand. Right. Now, the third kind of circuit, that is called as closed circuit. Now, closed circuit means this circuit has a provision to absorb carbon dioxide. How it can absorb carbon dioxide? By using soda lime. Soda lime is a chemical which contains calcium hydroxide, sodium hydroxide and potassium hydroxide, and basing on this chemical, that will absorb the carbon dioxide. Okay. So this closed circuit, the biggest advantage of the closed circuit is you can reduce the fresh gas flows. Reduce the fresh gas flows. But the disadvantage is the circuit has become bulky. So there are chances of disconnections are there. So there is no separate. If you look at the options also, if you have done your internship clearly also, you might have noticed any type of surgery, it might be whether it is cardiac, whether it is neuro, whether it is general surgery, whether it is breast case, whether it is orthopedic case, whatever it might be, we generally use closed circuit if it is a long duration procedure. Closed circuit, long duration procedure. Why we are using closed circuit means here we can reduce the gas flows. It will be very economical for the hospital. There is nothing like any surgery we have to use this circuit only. Only one indication is if the patient is spontaneously breathing, then I will consider Mapleson A circuit. This is not very commonly available. If the patient, if I want to use outside the hospital or very limited resource setting, then I will consider modified Mapleson D. Why I am saying it specifically modified means this is called Bain's circuit, which is commonly available in any hospital. If you are an intern also, if you are looking at this video, you go to your casualty, you can find this Mapleson D circuit, modified Mapleson D circuit. So this is for controlled ventilation. Generally, we don't use for longer surgeries controlled ventilation because the gas flows are very larger. So only in children we use a special circuit that is called as a Jackson-Rees circuit. Okay. Now let me show you the picture of it. This is A circuit where the APL valve is close to the patient end. A B circuit is also APL valve is close to the patient end. C circuit also APL valve is close to the patient end. In D circuit, see here, D circuit APL valve is away from the patient end. D circuit is away from the patient end, and in E and F circuit, there is no APL valve. Right. So I have given a small algorithm in the main video section, how to differentiate basing on the image. Again, I am telling you very clearly, till now they have not asked this question also. Maybe some of the resources they said, like, they will give you the picture and ask you what is this circuit. So don't worry about it. You can easily follow that algorithm and you can identify it. And this is circuit what we are talking about, that is called as Mapleson F circuit. Mapleson F circuit, because this is the first question. I have stretched it a slightly longer so that I can cover the important topics in this question. Okay, I hope with this question, if I am not wrong, 99.99% of the students, they have marked it correctly only, because this is not a new question. It's already repeated many times. Okay, now let us see the second question. A female following a road traffic accident. Now this is very, very important. Every time, this time also there was one question. Every time they ask one question on the road traffic accident. Yes, there was one question, if I am not wrong, in the surgery, they have asked about this pneumothorax also, right? So that question will be covered in the surgery. What is anesthesia question I am trying to talk about it? A female following a road traffic accident injured her chest. On X-ray, there is a fracture of 3rd to 5th ribs. Somewhere between 3 to 5 ribs. Some students have said it up to 8 ribs also. Okay. Pain was not responsive to the routine analgesics. Which of the following blocks should be given? INI-CET people, typically they ask about these blocks or the clinical application of the bus, right? Again, in the NEET PG, not many questions have been asked in the last 3-4 years regarding the blocks. But INI-CET people, because if you recall your November or 2020 or 21 session, they have asked about some what is called a block of the abdomen. Right, and in 2020 or 2022, I am not very sure, they asked about the block on this face also. Right, now let us answer this question. We'll not go into the previous questions. Let us answer this question. So there are some fracture of the ribs and routine analgesics are not working on it. What should I do? So every time in the video section also, I have said you this scenario. I have given intercostal nerve block, intercostal nerve block. Now intercostal nerve block is the standard, or the biggest advantage of intercostal nerve block is intercostal nerve block. The biggest advantage is, the pain for the rib. If it is fractured, what is the normal treatment for any fracture? You immobilize that fracture. But ribs are special kind of bones in your body. Even if it is fractured, you will not immobilize it. If you immobilize it, you are killing the patient. So ribs, they are in the anatomical alignment. So you need not immobilize it. That is the good point. That is the bad point for the patient. Why it is good point means you don't require any POP casting for the rib fracture. Right? But what is the bad point? Whenever you take deep breath, a patient will complain of pain. So, if the patient is complaining of the pain, that 2, 3, 4, 5, 6 ribs, so many ribs are fractured, then routine analgesics like your NSAIDs or opioids will not help you that much. So, in those situations, if there are multiple rib fractures, I will utilize intercostal nerve block. Now, intercostal nerve block, the biggest advantage is you can reduce on the dose of the opioids. Okay, you can reduce the dose of the opioids, because opioids, they cause respiratory depression. Already the patient is suffering when he is trying to take deep breath. If you add opioid, this might complicate the picture. Opioids causes respiratory depression. So the respiratory depression component, if you want to avoid, I will add intercostal nerve block. Now let us see the options and see. Now, is there any intercostal nerve block? Nothing is there. So how to choose it? Now again, go back to the basics. Now see here, where is cervical block? Cervical, the name itself is saying, if you use your brain also, you can easily understand it and you can easily answer it. Cervical, that is in the neck. So cervical plexus block. Generally, cervical plexus block is used for some surgeries of carotid endarterectomy, small lymph node. Suppose sometimes tuberculosis is there, surgeon wants to do this lymph node biopsy, or for thyroid surgeries, you can consider cervical plexus block. Cervical plexus block, again, we have got superficial cervical plexus block and deep cervical plexus block, which we have discussed in the videos. In that video, I am very sure I have shown my image only. Right? Okay, right, leave it. So cervical plexus is obviously, it is not the area where we are going to block. Now coming to the last option, lumbar epidural. Lumbar itself is saying it is in the lumbar region. So obviously lumbar region means L1 to L5. So this is also not a right option. Lumbar epidural is generally used for post-operative analgesia if it is an abdominal surgery, lower abdominal surgery more particularly, or it is for labor analgesia. Right? So generally lumbar epidural we reserve it for lower abdominal surgeries, lower abdominal procedures, or normal delivery also. Okay. Next comes a supraclavicular. Supraclavicular, we showed this video also. In the supraclavicular, the name itself is saying here you are putting the needle, supraclavicular. And whenever this is supraclavicular, the real name is brachial plexus block. The moment if you know supraclavicular brachial plexus block, that means brachial plexus is supplying to this upper limb. So obviously this is also not the right answer. Then what is left over? The correct answer that is left over is thoracic epidural. Thoracic, the name itself is saying. So you can easily mark between T1 to T10 or up to T12 also. Okay, you can go up to it. But here the rib fractures are between 3, 4, 5, 6, 7, 8 ribs or third to fifth rib. So in between any of these ribs, you can put the epidural, you can pass the catheter and comfortably you can manage the patient. So what is the correct answer? The correct answer is thoracic epidural anesthesia. This is wonderful option for fracture of ribs. Yes, one or two rib fractures are there. I will go for intercostal nerve block. Now you might get a doubt, sir, why this thoracic epidural? Why are you not blocking a lot of intercostal? All the areas you can block the intercostal nerve block. Now here I want to add one more important MCQ that has not been asked in this examination, but repeatedly asked. Intercostal nerve block. This is the one area where there is a high possibility. There is a high possibility of local anesthesia systemic toxicity. We call it as LAST. Local anesthesia systemic toxicity. Last 2 or 3 years in your NEET PG entrance examination also they have asked this. So patient will be prone to get local anesthesia toxicity with intercostal nerve block. So because this is the area where there is maximum systemic absorption of the local anesthetic. So that's the reason why it is prone to get local anesthesia toxicity. Now if there are 3 or 4 ribs fractured simultaneously, if I go on giving this block, there will be more absorption of the local anesthetic leading to local anesthesia toxicity. So if there are multiple rib fracture, I will go for thoracic epidural. If there are 1 or 2 rib fractures, I can go for local anesthesia systemic toxicity. No sane examiner will give you both options. That is for sure. Okay. So don't worry. This is a pretty straightforward question. Use your logic also. You can easily answer this question. Right. Now next question. What was asked? Which of the following drug will cause adrenal suppression? This is also a repeated question. This was asked in NEET PG 2017, 2018 also. Right. What is the correct answer? The correct answer is etomidate. Now for this etomidate, I have given a wonderful mnemonic. This is not my creation. This was given by one of the student in the offline batch. So what is that mnemonic? I will write down the etomidate spelling. You will understand all the features of etomidate. Right. Now once you understand this spelling and this mnemonic, you will never forget it. E for emetic. E for emetic. Okay. E for epileptogenic. Epileptogenic, it might cause. Okay. O for oily. Oily means which oil it contains? It contains propylene glycol. Now we all know if at all any solution or if at all any substance what we are giving intravenously, if it is oily, it is painful. So painful. T for tortures the hand. What a creativity. Tortures the hand. What a vision. See here, tortures the hand means what? Painful. So any oily preparation are painful. Can you tell me another oily preparation what we use in our anesthesia practice which is painful? Yes, you are right. The answer is propofol. Propofol is also an oily preparation. Propofol is also an oily preparation. It contains soya bean oil. Okay, this is extra point. Okay, right. So T for tortures the hand, that is painful. M for myoclonus. Myoclonus means sudden involuntary or jerky movements of the limb. So if we are infusing etomidate, it will cause jerky movements of the limb. That is called as myoclonus. I for inhibits adrenocortical synthesis. Adrenocortical synthesis. Wonderful drug, but this is the bad property, adrenocortical synthesis. Right? This question was asked multiple times in your examination. Right. Then coming to the last one, date. I have written this date in one box. Dates. Date means not your February 14th date. We are talking about. We are talking about eating dates. Eating dates are rich in iron and contains good amount of antioxidant. If you eat one date, what will happen? It will protect your heart from this all atherosclerotic effects and all these cardiac ailments. So dates are very good in protecting heart attacks. In the same way, dates, itomidate, is the most cardiostable. What a vision, what a thought. Right? So this kind of mnemonic, I don't have that much amount of talent, as I said you. This was created by one of the student in the offline batch, and he told me. So I found it interesting because all the points of itomidate is there in that spelling only. So obviously you can easily remember it. So most cardio stable. So that's the agent of choice for cardiac surgery. It is used for DCO cardioversion. All these features will be covered with itomidate. So what is the correct answer? Itomidate, and it is not a surprise question for you, right? Now let us see the next question. What has been asked? Right. Which of the following is incorrect regarding incorrect? That means false statement regarding thiopentone sodium. Right. Now, for this, every time thiopentone sodium, if you have seen my videos also, I have said thiopentone sodium, wonderful drug. It is an yellow color. That's the reason why I have marked here. No, not that reason, because this color is marker is yellow. I have marked it. So it's a yellow color powder like substance with a pH of 10.5. Right. Now, what is the unique feature of thiopentone sodium is if you start giving thiopentone sodium in your body, within 15 seconds, it reaches to your brain. This is called as arm brain circulation time. Okay. Now, what happens once this goes to the brain, it will not sit there quietly. Why? Because it is a highly lipophilic substance. All these points we have discussed in the video and we have written in the notes also. It's a highly lipophilic substance. The moment it is highly lipophilic, it goes to the brain, but it will act on the GABA receptors and it will cause sedation. So you start giving, you might have seen in many Hollywood movies also, when you start giving the drug, you ask the patient to count from 15 to 1. So 15, 14, 13, 12, 11, 10, 9, 11, 6. The patient will be knocked off. Right? So 15 to 1, before he counts up to the 1, the patient will go to the sleep. But after 5 minutes, the patient will get up from the sleep. And once he get up, he will not be fully conscious, but he will be like something drowsy like this. He will be talking, right? So why this is happening? Because thiopentone sodium is a highly lipophilic substance. The moment you give thiopentone sodium, it reaches to the brain. So from brain, it will go and deposit in your fat. Wherever there is fat in your body, it will go and deposit. Why? Because it is highly lipid soluble. So what will happen? The moment the concentration of thiopentone is decreased in the brain, after 5 minutes or 6 minutes, you see the patient will wake up from the sleep. Again, after 5-6 minutes, you see the patient will be sleeping. Why? From the fat, the drug will be going on, because all the time the fat gets saturated. So from the fat, it goes to the brain and it will cause sedation again. So the patient will be going to the sleep, waking up, going to the sleep, waking up, going to the sleep, waking. And this is a unique feature of thiopentone sodium, and this is called as the termination of action is called as redistribution. Redistribution. I have said it many times in the revision sessions or in the routine classes, in the offline classes also. Now let us see the options and see. So it is a lipid soluble substance. That's the right answer. We have to identify the false one, right? It achieves maximum concentration in the brain after an IV infusion. Yes, I said you arm brain circulation time. Circulation time, that is 15 seconds. 15 seconds, right? Redistribution to adipose tissue and muscle is seen. Yes, highly lipophilic substance. So what is left over? 3 options are ruled out. Rapid decline due to the effect renal excretion. No, the rapid decline is due to redistribution. Now, any drug, 99% of anesthetic drugs, they will be metabolized in your liver only. Liver. The decline, rapid decline, is due to redistribution, not due to renal excretion. So in the liver, this cycle of going to the brain, going to the fat, going to the brain, going to the fat will continue for around 10 to 12 hours. After a single dose of thiopentone sodium, the patient will be waking up, going to the sleep, waking up, going to the sleep up to 10 to 12 hours. Right? So after 10 to 12 hours, in between, what will happen? It will go to the liver, it get hydroxylated and excreted renally. renally excreted, because anything which is non-ionized, it should be converted into ionized form, then only it can be easily excreted. But this happens after a long time, not immediately, right? So the correct answer is rapid decline in its effect is due to renal excretion is a false statement, and this will be the correct answer for your entrance examination. So this also is a pretty straightforward question, right? Now let us see the next question. Which of the following must be avoided in a patient with poor cardiac arrest resuscitation care? And again, this is a straightforward question. Why not straightforward, but this is one of the star area after 2020. Every year they are asking one question definitely on advanced cardiac life support, basic life support, and also advanced cardiac life support doesn't end after getting the circulation. Post cardiac resuscitation care, that has been included in 2020 guidelines. So from 2020, I have also started telling you about this guidelines, post resuscitation care. It's there in your notes also. If you want, please see there. That is called as neuroprognostication. We call it as neuroprognostication. Why we need to prognostication? Why we need to evaluate neurally? Because there are many in our country. I'll tell you the fact. In our country, after a cardiac arrest is done, majority of the times we are unable to save the patient because we don't have that much amount of infrastructure, right? But in foreign countries, whenever there is an arrest, you get the defibrillator, AED, everything is done. People know, trained. The scenario is changing in our country, right? But in foreign countries, what happens is they will do the resuscitation. Once they see this, and they are shifting to the ICU, they are doing the intervention. After doing everything, what is happening, the patient's, the brain has went into an irreversible damage state. Now that is adding a lot of burden on the hospital, because the patient is, you can't say technically that he is dead, because the patient will be having some amount of activity, but his brain will never recover from the hypoxic insult that has been happened during the cardiac arrest process. So from 2020, the American College of Cardiology and American Heart Association, it started giving its own guidelines about neuroprognostication. What should I do? So once the patient has got a ROSC, return of spontaneous circulation. First we'll see the theory, then we'll let us rule out the options. So once the patient has got return of spontaneous circulation, that means maybe patient might have this ventricular fibrillation. You have given the shock. Imagine a situation like this. Patient has got ventricular fibrillation and you have given the shock, and he has got normal sinus rhythm. The moment he got the normal sinus rhythm, everything is fine. Then first thing what you have to do according to the guidelines is stabilize the patient. Stabilize the patient. That means if the patient has not been intubated, so put the endotracheal tube. That means advance airway. Advance airway. Right. So advance airway. The moment you put the endotracheal tube, the job is not over. You have to connect him to the ventilator. So connect him to the ventilator. Okay, and what you have to do is you have to maintain the blood pressure. Why? Because if the patient, because of cardiac, the heart itself is not functioning properly, or it has recovered just now. So if it is not maintaining the pressure, so it will reduce the blood flow to the brain. The moment it reduces blood flow to the brain, again you might suffer from ischemia. Right. So what happens is you have to maintain the blood pressure. How much you have to maintain means greater than 65 millimeters of mercury. That's a mean arterial pressure, mean blood pressure. Okay, you have to maintain the mean blood pressure. Now you have to identify the heart is not functioning properly. Maybe this ventricular fibrillation is due to some thrombosis is there. So he might have STEMI or ST elevation myocardial infarction. If you find out any cardiac issues, cardiac intervention, because that is the goal, right? Your heart is your pump. You have to improve the pumping efficiency. So if at all your heart is not pumping properly due to any coronary thrombosis, you have to plan for any percutaneous intervention, something like that, right? Now once you do all these things, you have to assess the patient neurological status, because once the heart has been recovered, you have to assess the brain of the patient, assess the neurological status of the patient, assess the neurological status. If the patient is awake, if the patient is awake, that means he is mentally, that means brain has not encountered the ischemic insult. But if the patient is comatose, immediately you have to institute targeted temperature or TTH, targeted therapeutic hypothermia. targeted therapeutic hypothermia. You have to reduce the body temperature to 32 to 36 degrees up to 24 hours. Why? Because hypothermia itself is a brain protective agent. Now, very important is at this period, you have to make sure the patient doesn't develop fever. You have to reduce the body temperature by using ice cold blankets or giving a ice cold saline infusion, giving some, so that the core body temperature reduces up to 32 to 36 degrees centigrade. So you have to do this up to 24 hours. After 24 hours, if the patient is still not responsive, then slowly rewarm the patient. Slowly. After 24 hours, you have to slowly rewarm the patient and get an MRI done. You have to get the MRI done. And in the MRI, see if there are any changes of ischemic insult that has been happened during that cardiac arrest event. Suppose if you can't find it, you can also get EEG. You can see the somatosensory evoked potentials or get an EEG done, and within 24 to 72 hours, you can measure one enzyme level that is called as NSE, that is called neuron specific enolase. This is one enzyme that is an indicator of some damage that has happened during this. So, by doing this, we can come to a conclusion that the patient brain is active or not. Okay, so all these points we have documented in this algorithm. So see here, return of spontaneous circulation is obtained, manage the airway, maintain the respiratory parameters, the saturation between 92 to 98%. Saturation. Carbon dioxide also should not be making sure that 35 to 45, it should not go up or down. So carbon dioxide is very important influencer of your cerebral perfusion. So carbon dioxide level should be maintained between 35 to 45 millimeters of mercury. Maintain the hemodynamic parameters. Systolic blood pressure 90. I am more interested in mean arterial pressure should be more than 65 millimeters of mercury. Mean arterial pressure should be maintained greater than 65 millimeters of mercury. Obtain a 12 lead ECG. STEMI. Consider for emergency cardiac intervention. If the patient is having ST elevated MI, go for cardiac intervention. Now see here, follow the commands. If the patient is comatose, TTM, I said TTH, targeted temperature management or targeted temperature hypothermia. We have to make it hypothermia 32 to 36 degrees, then get a CT scan, EEG or other critical care management. Okay, right. If the patient is awake, then it's okay, fine. So this is what the more specifically, this guideline, this image was given by ACC AHA, and this I have shown you in the main videos also. See here, within 24 hours, you have to perform a CT scan. Targeted, you have to institute TTM, targeted therapeutic management, get a CT scan. If possible, get a CT scan. But after 24 hours, see here, this is the timeline. ROSC has happened. This is 24 hours. After 24 hours, what you are seeing? So you are slowly rewarming the patient. Slowly. You should not rewarm very quickly. And in meanwhile, what you have to do is you have to get an MRI. You have to get a somatosensory evoked potentials or get an EEG done. So see here, get a status record for any myoclonic activity of the brain. And in after 24 to 72 hours, can you see here? There is we will check the levels of NSE, neuron specific enolase. Neuron specific enolase. So our people have asked this question long, this question, these guidelines have been framed in 2020. They are going to change in 2025. Every 5th year, they are going to change. If there is some change, they are going to change in 2025. Now, they have asked this question, this therapeutic prognostication or neuroprognostication of the patient after ROSC, they have asked in your entrance examination. We have discussed all these things in the main videos of what to do after ROSC, right? Now, let us see the options and try to answer it. Now, see here, maintain the mean arterial pressure of over 65, right? Yes, mean arterial pressure, just now I am telling you 65. Maintain SpO2 be above 94, 92 to 98 is the correct one, right? That's also a right one. Revascularization procedure if the patient develops ST elevated post resuscitation. Yes, if the heart is not pumping properly, you have to do cardiac intervention. Bring the body temperature below 32 degrees. Once you know this answer, if I explain you, then the answer is very, very clear in front of you. This is the false statement. This should be avoided. You have to maintain between 32 to 36 degrees centigrade. You should make sure the patient doesn't go into pyrexia. So what is the correct answer? This is bring the body temperature below 32 if targeted therapeutic hypothermia if unresponsive. So this was asked, or this is a almost a straightforward question. Those who have done the regular videos about the basic life support, advanced cardiac life support, genuinely, so this question has been, they can easily answer this question. Okay, right? So shall we see the next question? Right. Now, this is the bouncer question. Ambu Aura 40. I don't know why this question has been asked in your entrance examination without an image. I have added this image. Why I added this image means in the main video section, I'm not boxing myself, but I wanted to tell you. In the main video section, I have demonstrated how to put an LMA in a child. Right? This when in my practice I have done this. So many times we do this LMA. So in one of the patient, I have taken after taking the consent and all the things. I have introduced an LMA. In that LMA insertion video demonstration, I have used this AMBU LMA. I have said it in the video, but I never expected. Why? Because all these days, in the last INI-CET also, there was one question on LMS. Okay, so LMA, they asked which of the following is a second generation LMA in the last INI-CET question. Now, here they have asked AMBO ARA is an example of which type of LMA. Is it a first generation, second generation, third generation, fourth generation? Obviously, you can rule out two options. There is no third and fourth generation LMA. So, these two options are ruled out. So, these two options are ruled out. Right? No, the biggest question, I don't know, they should not promote any, I am not very sure. I don't know the rules also, but yes, Ambu is a company name, right? Ambu is a company name. Why they are asking about this Ambu Aura 40 without an image, an undergraduate, how to identify this Ambu Aura 40? 40 means what? Means it can be reused up to 40 times. Reused up to 40 times. Okay, so if you want me to show the picture, this is the Ambu Aura 40. Out of all the LMAs made by the Ambu company, only one LMA, that is a second generation LMA, that is called as Ambu Aura Gain. Aura Gain. This is the image of Ambu Aura Gain. Can you see here why it is called second generation? Means second generation LMA means it should have a drain tube. It should have a drain tube. That's it. It should have a drain tube. So then only you can call it as a second generation LMA. So this is Ambu Aura 40. At least they should have provided some image in the entrance examination, because there are so many companies are there which are producing LMS, right? Ambu is one of the company which is producing it, right? Now asking about a company in the examination, how it is justified by the examiner side, I don't know. Yes, the correct answer is supraglottic airway with a first generation LMA, right? Ambu has got only one second generation LMA, that is called as Ambu Aura Gain. I use generally this Ambu single use, or I use Auraflex generally in our hospital, because I don't know the logistics behind it, but we got lot of Ambu LMAs. That's the reason why I have taken, where I am practicing, we use lot of Ambu LMAs. That's the reason why I took the video after the consent. And in that video also I said this is a special kind of LMA that is called as Ambu LMA. Right. So in this LMA, we are inserting this LMA. This is a first generation LMA. Slightly tricky question. Out of all the 6 questions what we have discussed, this is only one question. I don't know why they particularly asked about it. But yes, the probability of getting correct is 50%. Why? Because you can easily rule out there is no third generation, fourth generation. So theoretically, we have discussed. I don't say I have discussed this topic in my routine videos also. I will be straightforward to you, because if I start telling you about all LMAs and different company names, it will entirely make your videos cumbersome. Right? So we have to know is whether it is a first generation LMA or second generation LMA. So second generation LMA, the classic example is ProSeal LMA. ProSeal LMA. Many times this question has been asked, or even if they have asked iGel, I would not have been that much, surprised. Why? Because iGel is also a second generation LMA. Or if they have asked about LMS Supreme, LMS Supreme is also a second generation LMA. But unfortunately, they have asked Ambu LMA, Ambu Aura 40. In Ambu, there is only one second generation LMA, that is called as Ambu Aura Gain. Okay, so this is Ambu Aura Gain. So there are some second generation LMA. Rest of all are first generation LMA, which includes LMA Classic, LMA Fast Track, Okay, so many AMBU LMAs, all these, rest of all, they belong to first generation LMA. Okay, so this is slightly tricky question. Out of this, two options can be easily eliminated. So the probability of getting correct is 50-50 percentage. Yes, I can't help you on that much. So, but I hope most of the students might have written it as first generation LMA only, or some students they said, sir, we have marked it as second generation. Yes, unless they show some image also, it would be very better. I don't know. I'm not very sure because this is a recall session. If they have showed the image and you made a mistake, then it will become a blunder. Okay. So I think these are some 6 questions that have been asked in your entrance examination. So don't worry about this. As I said you, every time anesthesia has got 5 or 6 questions in whatever might be the pattern of examination. The standard questions they ask when those students who are preparing for the NEET PG and rest of the students also, please make sure you go through this airway management mandatorily. You go through about the basic life support and advanced cardiac life support mandatorily. You go through about the drugs what we use, because in the recent NEET PG they have asked a lot of questions on local anesthetic. Here they have asked about IV induction agents. So if you ask me to mark 3 areas in the anesthesia, these 3 areas I will say. Okay, advanced cardiac life support, basic cardiac life support. There was one question on drugs. There will be one question definitely on the airway management section also. Yes, there are 1 or 2 questions in anesthesia. I don't say they are particularly of anesthesia, because there was one question on pediatric resuscitation also. So that will be discussed by the pediatric faculty. And there was one question about enhanced recovery after surgery. That will be generally discussed by your surgery faculty. So I wanted to discuss exclusively anesthesia questions, sir. So with this, I conclude my session. I hope all you guys have written your INI-CET examination very well. So if at all, if I have missed out any question, feel free to comment here so that I can answer you. Okay. Wishing you all the very best for your future. Thank you.